Welcome back to the deep dive. Today we are tackling something um, really urgent and complex, but also a field that's just changing so rapidly.
It really is.
We're focusing on the stiffening heart, specifically restrictive cardiomyopathy, or RCM.
And the number one cause behind it, which is amyloidosis.
And our sources, we're pulling from the latest clinical consensus, major medical texts, and they all make one thing incredibly clear.
The old idea of RCM as this, fixed end-stage diagnosis, that's completely obsolete.
Right, because now there are these powerful, very specific
Yeah.
therapies.
Which means that accurately diagnosing which type of RCM you have is now probably the single most critical factor that determines whether a patient lives for months or for many years.
So that's our mission today. We need to get past the general symptoms. We want to understand the mechanics of the stiff heart, what's actually happening.
And then dig into the proteins that cause amyloidosis, specifically AL versus TTR. They are completely different diseases.
And then we'll walk through the diagnostic toolkit, which is just fascinating. A lot of it is non-invasive now, and it lets doctors distinguish between, a disease that's a sprint versus one that's a marathon.
Okay, so let's start with the basic physics of the problem. Restrictive cardiomyopathy is at its core a failure of diastolic function.
Okay, so diastolic function, that's the filling phase of the heart.
Exactly. The core issue is that the ventricle is non-compliant. It's rigid.
So wait a minute. If the pumping function, the systolic part, is often pretty well preserved, why do we even call this heart failure? Doesn't that term imply the pump is weak?
That's a great question, and it's where the traditional definition really falls short for RCM. In classic heart failure, like a dilated cardiomyopathy, the pump is weak.
Right.
But here, the heart's actual strength might be near normal. The failure is a structural problem. It's an inability to properly receive blood.
So instead of a flexible balloon, it's more like a concrete box.
That is a perfect analogy. It can contract powerfully, sure, but it can't relax and expand enough to pull in the blood it needs from the atria.
So what does that mean for the actual numbers, for the contractility?
Well, the ejection fraction, or EF, which is how we measure that squeeze, is typically only mildly decreased. Our sources put it somewhere in that, say, 30 to 50% range.
So not great, but not terrible either.
Exactly. It's not optimized, but the dominant problem is that lack of compliance. It's restricting how much blood can even get in to be pumped out.
And that rigidity, that stiffness, must create this massive pressure problem upstream, right?
Immediately, and absolutely.
Yeah.
Because the ventricles are so rigid, the end diastolic pressures, that's the pressure inside the chamber right before it squeezes, are just chronically severely elevated.
Of both ventricles.
In both the left and the right, yes.
And the atria, the chambers that are trying to push blood into this concrete box.
They're under incredible strain. They're forced to push against this constant high back pressure.
Yeah.
So over time, what happens is they become enormously enlarged.
They're trying to compensate.
They are trying to generate enough force to feel those rigid ventricles. And this biatrial enlargement, sometimes it's described as massive, is a classic finding in RCM.
So moving to the clinic, how would a person first even notice this is happening?
It's insidious. The onset is so slow. The very first symptom is usually just a subtle exercise intolerance.
Something you just brush off as, getting older.
Precisely. Which means by the time a patient actually presents to a doctor with, obvious heart failure symptoms like swelling, the disease is already quite advanced.
And the sources really highlight a specific pattern in the symptoms, which seems like a huge clue. They say patients often have more right-sided symptoms.
Yes, even though the filling pressures are high on both sides of the heart.
So why the right-sided dominance?
It really just comes down to the body's plumbing. The right side of the heart gets all the blood returning from your body's veins.
Okay.
So when that right ventricle is rigid and backed up, that pressure shoots directly backward into the systemic circulation.
And that's what causes the visible symptoms.
That's it. You get peripheral edema swollen legs, abdominal fullness, ascites, which is fluid in the belly, and those symptoms often overshadow the shortness of breath from the left-sided failure, at least at first.
So if a clinician has a patient in front of them, what are the classic physical exam clues that would make them think RCM? I know one involves the neck veins.
Yes, the jugular venous pressure, or JVP, is critical. It's almost always elevated, but it's the movement of the JVP when the patient breathes that's the giveaway.
You're talking about the positive Kussmaul sign.
I am, and we should break that down because it's completely paradoxical. It's the opposite of what should happen.
So normally when you take a deep breath in,
The pressure in your chest drops. It creates a vacuum effect that sucks blood from your veins back towards the heart. So your JVP, the vein in your neck, should visibly go down.
But not an RCM.
Not RCM. Because the right ventricle is so rigid, it's infiltrated with this stiff material. So when that extra blood rushes back during inspiration, the ventricle can't expand to accept it.
The concrete box can't stretch.
Precisely. So the blood has nowhere to go but backward, and you see that pressure spike immediately in the neck veins. The JVP paradoxically goes up.
That's a huge flag.
It's an immediate flag. It narrows the possibilities down very quickly.
What about listening to the heart? The usual sounds of heart failure, S3 and S4, they're a bit different here.
Right. We often listen for an S3 gallop in, a big, floppy, volume-overloaded heart. But S3 marks rapid early filling, and that just doesn't happen in RCM because it's so stiff. So an S3 is very rare.
And an S4, the atrial kick.
A fourth heart sound, an S4, is technically more common than an S3, but even that is often unusual in advanced disease.
Why is that? You'd think the atria is working so hard they'd make a lot of noise.
You would, but it links right back to the pathology. The atria themselves are often heavily infiltrated by the same amyloid material. So even though they're trying to contract forcefully, the atrial muscle is just too stiff and weak to generate an audible S4 sound.
So it's a sign that the entire heart, not just the ventricles, is affected.
The entire cardiac architecture, yes.
Okay, so RCM is this mechanical failure, presents with a right-sided bias, unique physical signs, but we need to categorize the causes because you can't treat it unless you know what's making it stiff.
Right. We break the causes into three main pathological buckets. The most common is the infiltrative category.
So something is getting between the heart cells.
Exactly. Abnormal material is physically depositing between the cardiomyocytes, separating them, distorting them. And amyloidosis is the king of this category.
What's the second bucket?
That would be the storage category. So this is where abnormal stuff gets trapped inside the muscle cells themselves.
Like what?
The classic example is hemochromatosis, which is iron overload, but also things like Fabry's disease. What's interesting about iron is that it can start as an RCM picture, but over time, the toxicity can actually weaken the heart and make it look more like a dilated cardiomyopathy.
And the final group?
That's the fibrotic group. This is basically scarring. RCM that results from some kind of injury. So you see it after extensive radiation to the chest, in some autoimmune conditions like scleroderma or other rare things.
But the common thread for all three is the ventricle loses its ability to stretch and relax.
It leads to that same restrictive state. But the critical point here, and the whole reason for this deep dive, is that we have to identify the cause, especially if it's amyloidosis, because we now have specific life-altering treatments for it.